My name is Syarifah Nazihah. I'm an anesthetist from Hospital Chancellor Tuan Putris, or known as HCTM. Sorry, UKM. So before I start my presentation, I would like to thank the organizing committee for inviting me to come to this prestigious event, very glamorous opening event, which I enjoy very much. So I consider this as one small step for all of us. We are gaining a new knowledge today. It's a one small step for us, but it's a huge leap for mankind. Okay? So I also like to congratulate all the participants who from Terengganu or even from outside who come here all the way to Terengganu. I believe 50% to enjoy Terengganu food and also scenery, and another 50% to gain knowledge. Okay? So thank you very much. Before I proceed, any of you have seen Harry Potter before? So when Harry Potter wants to open the Meridian Smart, it says that he declared that I solemnly swear that I am up to no good. So here, before I start my presentation, I would like to declare that I have no conflict of interest. Okay? So any suggestion or any recommendation that I've given today is based on evidence-based and is nothing personal. For this is the content of my presentation. After go through a brief introduction, I will talk on the causes of unanticipated hospital admission after ambulatory surgery. Following that, I will talk about little on pre-operative anesthetic consideration, intraoperative anesthetic consideration, and a very small portion of a post-operative consideration. So I think Dr. Chan Wen-Ken has done a great job explaining the assessment and the suitability of the patient surgery status for ambulatory care. So I will not touch on that. Okay? So ambulatory anesthesia has revolutionized the field of surgery. It's allowed expanding range of procedure to be performed on outpatient basis. And the benefit has been shown before, it include reduced healthcare costs, improve patient satisfaction, increase availability of surgical service, and also reduce patient morbidity and mortality. So the anesthesiologists aim to provide optimal pain relief, relaxation, and safety throughout the procedure, and ensure the smooth and swift recovery. The primary goal is to achieve the right balance between the adequate pain control and minimal side effects, and allowing the patient to return to their normal activities as soon as possible. So what would be the ideal or the best technique for ambulatory surgery? So it is called fast track general anesthetic technique. Okay, so this is the concept that is worldwide accepted for ambulatory care. It says that the fast track general anesthetic technique will ensure the rapid returns of consciousness and protective reflex. So it have a minimal residual effects that can cause the complications. Okay? And it will allow and facilitate early oral intake and early ambulation. And we know that our anesthetic drugs generally cause reduced ventilatory response and compromise airway patency, which will cause complications following surgery. And the combination of the anesthetic drugs, meaning the analgesic, anesthetic, neuromuscular blocking agents, will have a synergistic effect on the post-operative cardiorespiratory complications. So we want to use the short-acting and administered at low dose possible. So before I proceed, we want to identify what will be the cause of unanticipated hospital admission following the ambulatory surgery. So the devil is in the details in this publication, whereby it is published in 2020, Incidence, Prediction and Causes of Unplanned 30 Days Hospital Admission After Ambulatory Procedures. So this is a retrospective study involving more than 1 million data, okay, about 1,400,000 data in US. So this retrospective study actually looked for the 3 risk factors that increase the risk of hospital admissions following ambulatory surgery. So they divide these factors into patient factors, intraoperative characteristic, and procedural factors. Okay, so we want to know what is the intraoperative characteristic that is important, that can influence the success of the ambulatory surgery. Number one is the time within the operating room. Okay, so as anesthetists, we are not at fault for the timing. Okay, most of them caused by the surgeon. Sorry, surgeon here. Emergency surgery procedures, effective dose equivalent of inhalational anesthetics, intraoperative fluid volume, total intraoperative norepinephrine equivalent dose, neuromuscular blocking agent, and also total intraoperative opioid dose. Okay, so this study is a retrospective study from the US. So you can expect that they also do a emergency procedure as a outpatient or as an ambulatory procedure. So they found out that among these characteristics, only one factor actually cause hospital admission following ambulatory surgery, which is the emergency procedure. Okay. So you might be asking why this other intraoperative characteristic is not significant. It could be because the intraoperative anesthetic management quite similar or quite the same among the patient. Okay, so what would be the difference is because of the patient factor and also the surgical factor. However, we as anesthetists should ensure that we stick to a fast-track general anesthetic technique, so that we do not be the person who actually cause readmission or prolonged stay in the ambulatory center. So following this study, they actually do a risk prediction score for admission following ambulatory surgery. I don't know if you can see this, but you can look at the journal later, and we can actually use this risk prediction score for our practice later, whereby the important points is actually the patient's comorbidities, which is COPD, diabetes mellitus, peripheral vascular disease, liver disease, congestive heart failure, depression, anemia, severe renal failure, drug abuse, and malignancy. So this is among the factors that significantly increase the risk of hospital admission. Okay, so each of risk factors will have the points given, and the highest point given for malignancy. Okay, so for example, we have 64-year-old with COPD and diabetic mellitus underwent urinary stenting, for example. So we can see that COPD had 2 points here, with diabetic mellitus 2 points, and urinary stent system is 16. So we have total of 20 points. So 20 points carry 3.2% of hospital admission following ambulatory surgery. So this is how you use any type of risk predicting tools. Okay. Okay. So next, I will move to anesthetic consideration. I will divide into preoperative, intraoperative, and a small portion of postoperative. For preoperative assessment, I think I will not go into the detail. I will definitely not go into the detail because the detail has been spoken to by Dr. Chan before. Apart from the general medical assessment, airway assessment, screening for OSA, the two important things that we have to look for is the anesthetic history and also the history of PONV. Anesthetic history, apart from allergy, previous reaction to anesthetic drugs, or last meal, for example, the other important anesthetic history that we have to look for is a risk of post-operative pain in a patient who are having a chronic pain, or a patient at a risk of severe pain post-operatively, for example, in a patient with perioperative anxiety. So this is the patient that might be challenging to undergo ambulatory surgery because of the pain control post-operatively probably will not be similar between you and me. Okay, so basically those who have chronic pain or on a high dose of analgesic drugs probably will not respond well to our common analgesic for ambulatory surgery. So this kind of patient, you have to be aware, you have to keep the history, and you have to actually anticipate, and probably this kind of patient requiring extra treatment. Okay, but I will not talk on the pain management because tomorrow Dr. Wan Rohaida will talk in detail about the pain management and case discussion. So for PONV risk factor, the reason why I brought up here is because we have to be aware that PONV and nausea and vomiting is actually the major complications or the most uncomfortable side effects of the general anesthetics that the patient may have. Okay, so before we proceed with the surgery, we have to see the PONV risk factor that can be divided into patient anesthetic or surgical risk factor. So patient risk factor, those who had higher odd ratios of developing nausea and vomiting is female gender, history of PONV or motion sickness, non-smoker, and age. Okay, so basically a few months back I went to Pulau Kapas for a day trip, and I am the only person who are vomiting in the boat. So definitely if people want to GA me, they have to give me double or triple antiemetic. Okay, so apart from that, for anesthetic factors, the use of volatile anesthetics and also nitrous oxide are also post-operative opioids. For surgical factors, laparoscopic and cholecystectomy are having a higher odd ratios of having a post-operative nausea vomiting. And apart from history takings and examination, patient and family education is also important roles in before we actually embark the patient on ambulatory journey, because by giving adequate course of education to patient, it improves transparency and emphasize patient participation and patient engagement, and it can develop a realistic expectation towards preparation and post-operative pain management and also post-operative ambulation. And patients should also cease smoking 4 to 6 weeks and minimize alcohol consumption. So it's the same as our general anesthetic technique. So we move to intraoperative consideration. So the choice of anesthetic method is ideal anesthetic agent, whereby it has a rapid onset and offset, rapid recovery, there's no hangover effect, with a good analgesic control and treatment and prevention of PNV. So far up to date, we do not have this ideal type of anesthetic agent in one drug. Okay, so for example, if this is Jung Jungkook with BTS, okay, whoever who listen to BTS, so I consider him as an ideal human being. So if he is an anesthetic agent, he probably can be an ideal anesthetic agent. Okay. So what are the available options for intraoperative anesthetic agents? So intraoperatively, the most commonly we can give is actually a local anesthetic plus minus monitored anesthesia care, or general anesthesia using volatile or TIVA, and also regional anesthesia that can be divided into neural axial block or peripheral nerve block. I will not talk on local anesthesia and MAC, but most of the simple procedures can be done with a local anesthetic, with or without sedation. So usually anesthetic is not involved in this kind of surgery. So surgeons knows the best which patient can be done under local anesthetic and which patient cannot be done under local anesthetic. But local anesthesia with MAC probably the best or the most fast methods for patient in and out in the for ambulatory surgery. I will talk on volatile anesthesia. So the two common drugs that we are using is sevoflurane and desflurane. I no longer use isoflurane. I do not have it in my center. I have no idea if there's any other KKM hospital who still have isoflurane. So I'm not talking about isoflurane. Sevoflurane is the most common and it's cheaper definitely compared to desflurane. It has a minimal metabolism. The good thing is it is non-irritating to airways and it has a pleasant odor. So it's very suitable to use as an induction agent, particularly in pediatric surgery. For desflurane, it has rapid onset and offset with a low blood gas solubility. So it is very good for obese patient and also for elderly. He has a fast emergent and is also suitable for low flow anesthesia. Okay, so usually sevoflurane we don't use a low flow, but for desflurane we can use a low flow. I am comfortable to use up to 0.5 liter per minute. Okay, so we want to compare between sevoflurane and desflurane in ambulatory surgery because I believe many of you probably think that desflurane probably better because we can see that patient with desflurane actually can wake up more clear-headed and it really have a fast time to eye open compared to sevoflurane. So I come up across this data analysis in 2020. The primary objective of this trial is to look for the adverse respiratory event. However, they also look at other complications compared between these two inhalational technique. So this involving 13 trials, including 1,200 of the patient, and most of the study are randomized control trial. So I hope you can see this. But the primary objective is to look at the adverse respiratory event for desflurane and sevoflurane. We can see that the diamond shape is actually favoring the desflurane for adverse reaction, meaning that more patient in the desflurane group has adverse respiratory event following induction or following extubation. The incidence in desflurane is about 20% versus 12.8% in sevoflurane group. Okay. What about emergence agitation? Emergence agitations is the results is actually comparable, meaning it doesn't really matter if you use desflurane or sevoflurane, the patient will have the risk of the same risk of developing emergence agitation following surgery. The post-operative nausea vomiting also comparable between these two groups. Okay. However, desflurane has significantly lower time to eye open compared to sevoflurane. Okay, so this is what we have always seen. Okay, we can notice that patient in desflurane actually had a fast time to eye open. Okay, but we want to know whether this fast time to eye open is translated into a short time in post anesthesia care unit or recovery area. Okay, so they actually do another analysis of time to discharge from operating room or from the recovery area. They found out that even though the desflurane has a less time to eye open, however, the time to discharge from recovery area is the same between the two groups. Okay, so it doesn't translate into a shorter stay in a post-anesthesia care unit. So I leave it to you to decide which one you want to choose, either desflurane or sevoflurane. I think the desflurane probably is suitable or beneficial in certain type of the group of the patient, for example in obesity or very elderly patient. However, most of the time probably you can use a sevoflurane as the first choice of anesthetic agent. Again, I will leave it to you to decide your choice based on the evidence that I have presented. Next, I will talk on total intravenous anesthesia in ambulatory surgery. So the TIFA concept is very simple because you only need an intravenous cannulation for your only prerequisite. Okay? There is no need for a sophisticated gas delivery system or scavenging equipment. There's no need for time-consuming procedures such as block or neuroaxial technique, and there's no risk of block failure. Okay, and there's no risk of residual paralysis. And TIVA drugs are generally less toxic than inhalational agents. So if you want to be environmental friendly, then you can use TIVA drugs more. So in 2014, there's a comparison of TIVA drugs using propofol, TIVA and technique using propofol, comparing with sevoflurane or desflurane. So this is total of 18 randomized control trial involving 1,600. So I would say that this is quite a strong evidence, because this is the meta-analysis and systemic analysis of the randomized control trial. So it shows that, from this meta-analysis, shows that the unplanned admission is lower in a propofol group compared to inhalational. Apart from that, post-op nausea vomiting also lower in propofol group compared to inhalational. Okay, so the when you compare the sevoflurane plus versus propofol, the propofol actually had a lower incidence of post-op nausea vomiting, and the same with desflurane. So overall, propofol actually had a reduced risk of post-op nausea vomiting compared to any inhalational. However, post-discharge nausea vomiting, meaning that after the patient has been discharged from the hospital, the nausea and vomiting is actually the same. And the length of hospital stay was in propofol is actually shorter compared to inhalational. Okay, so from these three aspects, we already look. We can see that TIVA probably has a higher weighting in ambulatory anesthesia compared to inhalational. Okay. However, we have to look at one more very important factors, which all of us actually are very picky of. We always ask the drug reps whether the drug is cheap or not. Okay, so we want a cheaper options, right? We in Malaysia always want a cheaper option. So the cost analysis of propofol versus inhalational agent is actually favors inhalational, meaning that inhalational agent has conquer less cost in ambulatory surgery compared to TIVA. Okay, this results is actually slightly different from elective surgery, whereby the patient is admitted to the hospital. I think because ambulatory surgery itself is already reducing in cost. So by giving a propofol probably overkill. So propofol actually had a higher cost compared to inhalational. Okay, so based on the last factors, so the winner is inhalational. Okay. What about dexmedetomidine? So dexmedetomidine is ideal for ambulatory surgery. Personally, I think dexmedetomidine is quite versatile drugs, and it also had a very favorable effect. Okay, it has anesthetic sparing properties, whereby if you use dexmedetomidine, you can use a low dose or lower amounts of any anesthetic drug. It has analgesic properties. It allows spontaneous bleeding, and it prevents emergent delirium. Okay, so this is a very beautiful effect of dexmedetomidine that I think many of us like, because the patient, when awake, they are very calm and they are very composed. They are like just awake from the sleep. Okay. However, there are few drawbacks of the dexmedetomidine in ambulatory surgery. Number one, it cannot be used as a sole anesthetic agent. So because of this, it become not cost effective. And a patient may have a prolonged recovery in PACU, and it is probably more expensive, and it causes hemodynamic instability in a higher concentration or higher dose. So, one of the meta-analysis studying the effect of dexmedetomidine in a non-operating room anesthesia in adult shows that dexmedetomidine had a higher time until full recovery, and higher incidence of hypotension, and higher incidence of bradycardia. However, patients in dexmedetomidine group had a lower event of desaturation. Okay, so because of these two factors, which is these main factors, which is higher time until full recovery, I think it is probably not ideal to use as an ambulatory setting. However, dexmedetomidine is a a very good drugs that you can use intraoperatively. What about ketamine? Okay, so ketamine is a dissociative anesthetic that plays a significant role in analgesic and sedation, and it is among the earlier generation of ambulatory anesthetic drugs. Okay, it affects in MMDA receptors and opioid receptors, and it metabolizes into norketamine, which has 30% potency of ketamine. So because of this, it can have a prolonged effect. And the analgesic properties is achieved at plasma concentration significantly lower than those producing the loss of consciousness. So this is good because you don't need a full dose of 2 mg per kg of ketamine to achieve the analgesic effect. You can use a very low dose, for example 0.1 to 5 or to 0.5 milligram per kg, and you already get the analgesic effect of the ketamine. Okay, so if you remember, this is the 13 boys that actually trapped in Chiang Mai cave. I can't remember what they are doing in the cave, but they are doing some meditation, and then they are trapped because of the flood. And the hero in this story is actually the anesthetist. Okay, this anesthetist used ketamine to sedate the boys, and they actually bring out the boys under sedation of ketamine out from the cave. Okay, so these doctors, apart from anesthetist, he is also a very experienced cave divers. Okay, so because of this, actually all the boys managed to come out of the cave unharmed. Okay, I do not find any actually meta-analysis or study on ketamine in ambulatory anesthesia, but I found one meta-analysis that the primary endpoint is to look for the effect of post-operative depression in ketamine, in a perioperative application of ketamine. So this is a randomized control trial with about 3,000 patients. Okay, the ketamine dose used is ranging from 0.1 to 5 milligram per kilo to 1 milligram per kilo, but mostly the studies use 0.5 milligram per kilo. So this is what the dose that we always use as anesthetic for adjunct the analgesic effect. Okay, so they found that post-operative depression significantly lower in ketamine group. Okay, that is their primary endpoint. However, the forest plot for adverse effect of ketamine compared to control is actually all favoring the control. For example, the first one is nausea and vomiting is higher in ketamine, headache is higher in ketamine, hallucination higher in ketamine, and dizziness also higher in ketamine. Okay, so this is all the undesirable side effects of the ketamine that we do not want to happen for our ambulatory patient, because we don't want the patient to have hallucination and saying that you are trying to kill the patient while the patient is at home. Okay, so it will be very scary for the family to take this. So they may think that this hallucination is a very serious side effect. Okay, so this is not desirable for ambulatory surgery per se. Okay, I will just talk a very little on the neuromuscular blocking agent, because sometimes we have no choice but we have to intubate the patient. For example, in laparoscopic surgery, we have no choice but still need to intubate the patient. Okay, so the ideal intubation, the ideal neuromuscular blocking agent should have a maximum patient safety, minimum comorbidities related to neuromuscular block, rapid recovery from neuromuscular block, and allows early extubation, and optimal neuromuscular block for intubation at the time when needed, and it must be cost effective. So this is the ideal type. Okay, but so far we do not have this ideal type yet. Okay, so we do not have the Jung-Jung-Kook type of neuromuscular blocking agent. But in general, we can use any type of short-acting or intermediate-acting drugs. For example, SARS or bivacurium we don't have, or intermediate-acting, for example, atropurium, cis-atropurium, vapuronium, or rocuronium. It is recommended to use a lower dose of rocuronium, which is at 0.2 0.3 to 0.45, it has been shown to have a faster recovery. However, the use of rocuronium in elderly may have a prolonged neuromuscular block despite the lower dose. So, whenever possible, we have to use the objective neuromuscular monitoring. And when we use rocuronium, ideally we should reverse with sugar MADEX. Okay, but this is all the ideal setting that we do not have in our Malaysian hospital. Okay, so is there any role of regional anesthesia in ambulatory setting? Okay, so this is a dilemma that we have been facing for many years. Basically, a spinal anesthesia is good because it avoids airway manipulation and it prevents the adverse effects caused by general anesthetic. And it also has a better pain control. However, the use in ambulatory setting remains questionable. Okay? We are not clear whether spinal anesthesia provides superior post-operative outcome compared to fast-track general anesthesia. And the limitation of spinal anesthesia, including prolonged onset, which is the most common problems, and then delayed offset. Okay, and it also can cause a urinary retention. Okay, so this can actually prevent the patient from going back home. So BGA Education has come up with one protocols on a spinal anesthesia for ambulatory surgery. In this paper, they actually mentioned that bupivacaine. The problem with bupivacaine is the onset occurs within 5 to 8 minutes. However, it can last up to 3 hours. And the regression of the block below the S2 level that allow mobilization and maturation is very slow, which is ranging from 240 minutes to 380 minutes. So, certain condition we can actually bypass this by giving a low dose intrathecal bupivacaine. For example, giving a saddle block, we can give a low dose which is adequate probably. However, low dose for bupivacaine sometimes carries the risk of unacceptably high failure rate. So they are actually suggesting for usage of prilocaine. It's still a mild local anesthetic, but it has a shorter duration of action, which is about 90 minutes. And the discharge from hospital after intrathecal prilocaine typically within 4 hours after administration, meaning that after 4 hours of administration of the spinal anesthesia, you can already discharge the patient because the patient already can mobilize and urinate by that time. And the dose up to 60 milligram can be used safely and effectively. So this is the protocols that they are suggesting. I know you cannot see, so I will just give you a brief overview. If the patient needs a saddle block, you only need about 0.5 to 1 mils of prilocaine. If the patient needs a block more than T10 block, you need about 3 mils of prilocaine. Okay? If the surgery is prolonged, then you can use a 2-chloroprocaine 4 to 5 mils. So if we still did not have prilocaine in Malaysia, but I think once we progress towards more daycare ambulatory surgery, I believe KKM will probably bring in prilocaine into the market. And because of that, we have to know that number one, we need to educate. Number two, we probably need to have the local protocols on management of post-operative urinary retention and post-dural puncture headache. Apart from that, we have to remember that because the action is fast, the patient may feel pain after the spinal has been wear off. So we need to supplement the analgesia with a local regional technique or systemic analgesia. Next, peripheral nerve block. Okay, so peripheral nerve block, we already know the advantage. It avoids general and neuraxia, better perioperative analgesia, reduce PONV incidence, and a faster post-discharge time, meaning that patient from OT can straight away discharge to the ward without having to go through the recovery area. And there's a lot of types of block. Okay, I think all of you are better than me in this. The common misconception in ambulatory surgery is we think that the patient need to be clear of the blood before the discharge, but actually it is not. Okay, the residual blockage post surgery is probably a desirable effect because it gave a post-operative analgesia. As has been told by Dr. Mr. Yai before, we are actually late 20 years from UK. Okay, so UK already done a meta-analysis on regional versus general anesthesia in ambulatory anesthesia in 2005. Okay, so it's almost 20 years ago. They already use a regional technique in ambulatory surgery. So it has been shown that anesthesia induction time is longer than general anesthesia, but PACU time is actually lower in regional. The pain score is significantly lower in regional. There's no reduced risk of nausea vomiting in regional anesthesia. Phase 1 bypass, meaning that the patient no need to go to recovery, can straight away go to the ward. High in regional, and need for post-operative analgesic. Patient is actually pain score is low. However, the time until discharge from surgical ambulatory surgical unit is actually almost comparable, but the patient has higher patient satisfaction. Okay. So the issue with regional anesthesia, personally, I think it's time-consuming to produce. Time-consuming to do. If we have a separate regional corner that we can actually induce the patient in between the cases, then it is a good idea. But if you want to make the surgeons wait for you to do the regional technique, I don't think they will be happy with it. Okay. But it is ideal if you have the regional corner or you have induction room to start your regional before the initial patient come out. The pain management, I will just talk briefly because my time is already up. Should be a multimodal non-opioid sparing analgesic technique. CM and NSAID or COX-2 must be a must drug unless contraindicated. And local and regional technique should be further enhance the pain relief. And after discharge home, we have to remind the patient that the analgesic must be taken around the clock, meaning that you don't have to wait for the pain to occur before you take the analgesic. You have to take the analgesic around the clock, meaning that CMQID, Celebrex PD, for example, or Atoxia OD, or okay. So patient also should be educated about non-pharmacological way of alleviating a post-operative pain. Okay, I'm lucky because this is my last slide. The post-operative consideration, we have to minimize the common side effect, which is pain, nausea, vomiting, and dizziness, as well as gastrointestinal and bladder dysfunction. So because of this, the preventive approach are necessary, and also the surgical wound care also necessary. Okay? So this is the view from my hospital at night. Okay, so those you are all welcome to come to HCTM anytime, especially those who are doing a master program in anesthesia. Okay, so with that, I would like to thank everyone. Thank you.